Okay, hello. Hi, everybody, and welcome to the patient advocacy session. This is part of our 42nd annual meeting of the American Association of Endocrine Surgeons. For the patients that are joining us, welcome. We are doing this in partnership with ThyCa. So this session is centered on thyroid cancer. And we really want this to be a part of our annual endocrine surgery meeting so that we can partner with our patient advocacy groups and gain a better understanding and education for all of us. And this year, our topic again will be thyroid cancer. And thank you very much to our panelists, Dr. Katie Hayden from Cleveland Clinic, Dr. Sarah Oatman from UT Southwestern, Dr. Stephanie Smoot-Pra from UCLA is our endocrinologist. And then I will be moderating. I'm from UCLA, as well as Dr. Joanna Ochoa, who is at University of Florida, Jacksonville. We're going to go through some cases to generate some discussion, and then we'll just go to our panelists to see what they would do. We've had quite a bit of questions that were submitted by our patient audience, so we're focusing on those questions. And for anybody in the audience, and specifically our patients, please feel free to put in the Zoom chat any questions that you have. And also, if there are times that you would like to share your experience, we would really love that as well. So just go ahead and put in the Zoom chat if you'd like us to give you an opportunity to share your experience by speaking or over the Zoom. Of course, we won't be answering any specific medical questions, so please keep your questions broad and general.
This is case one. I'm sure it's a lot of a situation which a lot of you can understand and probably have gone through it also. It is a 44-year-old lady with a 1.5 centimeter papillary thyroid cancer. She was found to have this incidental nodule on MRI. A follow-up ultrasound was done and displayed a 1.5 centimeter nodule with no high-risk features. No other nodules were seen, and normal lymph nodes were identified as well. On a FNA biopsy, papillary thyroid cancer was identified. Her thyroid function is normal with a TSH of 1.9. Dr. Smoot, I'm sure you get this question a lot from a lot of your patients. Are there any dietary or lifestyle modifications that can get rid of thyroid cancer?
Good morning, everybody, or good afternoon in Cleveland. Unfortunately, we don't have specific dietary changes or lifestyle changes that are going to get rid of someone's thyroid cancer. And this is a situation where you really need to lean in and talk to your endocrinologist, talk to your surgeon, and decide what the plan is going to be. I think one of the difficulties that we run into is that there is a lot of misinformation out there. So when you're reading things, when you're looking at things online, be sure that you've got an open relationship with your physician so that you can talk about things and gain an understanding of what's real, what might be, potentially a little bit helpful for just sort of overall lifestyle and what could actually be harmful for you.
Thank you.
So the next question that we get pretty commonly, and that was submitted by our patient audience, is it possible to not have any surgery at all for thyroid cancer? If you do have a thyroid nodule, even if it's been biopsied with thyroid cancer, is it an option to just watch the nodule and not do any surgery? And just as a very brief background, the reason that active surveillance has been suggested for small, low-risk papillary thyroid cancers is that there have been studies that the rate of progression is very slow with active surveillance of small cancers. Most of this data is from papillary thyroid microcarcinomas, where the tumors are less than 1 centimeter, so not really applicable to our case. But because we know that most thyroid cancers are not very aggressive, Dr. Oatman, what are your thoughts about active surveillance in general, and maybe for this case specifically?
So I think active surveillance is an excellent tool when someone knows that they're going to have reliable ability to follow up and follow closely with experts. People who are very familiar with all of the various different ultrasound findings that may indicate growth or progression of the disease, be it through extrathyroidal extension or any subtle changes in the lymph nodes. And I think having a very honest conversation with the patient about the longevity of being able to have that access for follow-up is really key. I work at a county hospital, so a lot of my patients worry about that as an option. And so in my daily practice, I don't get to talk about active surveillance that much. But I think for individuals who know that they'll be able to come back frequently, ideally have the same sonographer to be able to ensure that there's no subtle differences between the machine, the tech, or the person who's reading it. It can be a very good tool if someone would like to avoid surgery, or if there's someone who has significant medical comorbidities that addressing the thyroid cancer really isn't going to impact the quality of life or quality of life.
Yeah, I'd like to hear all of the panel's opinion because I think this is an important topic for our patients. Dr. Hayden, do you have any patients that you have active surveillance in your practice, and what are your thoughts about it for this case?
So I would agree with what everyone has already said, which is the most important aspect of this is to make sure that you have very good follow-up. And I agree with, ideally with the same sonographer, the same physician, knowing that there is a low but not zero risk of tumor progression or development of lymph nodes. So that really it would be probably a lifelong process that you're, entering into. I can think of one patient that I'm doing this on, and in her particular case, it's because of her advanced age. When I'm watching her closely, I have not yet started offering this routinely, even for people with low risk disease. But I do think that in the future we are going to be doing this more and more.
And finally, Dr. Smoot, there are some patients who I think have regret that they underwent surgery, and they wonder if maybe observation or active surveillance could have been an option for them, and maybe it wasn't discussed with them. So can you give your thoughts on who are appropriate patients in your practice that could be considered for active surveillance?
Absolutely. Dr. Levitz, I think you bring up an incredibly important point there that's relevant not only to surgery and active surveillance, but also use of radioactive iodine. And what I tell patients is that if things are changing and there are progressions in terms of, using less surgery or using less radioactive iodine, and they have already had their treatment, that they were treated with what was the known standard of care at the time that they were diagnosed. And that's really important. And while things change, we want to make sure that we keep our patients comfortable with the fact that if they were treated 10 years ago, these things weren't necessarily an option for them. So it doesn't mean that they were managed improperly. It just means that the standards are starting to change. In terms of the patients who I talk with this about, I think it's really important as an endocrinologist and as a surgeon to get an idea of what the emotional burden of this thyroid cancer diagnosis is for your patient. And we also use terms like medical minimizer or medical maximalizer, thinking about where somebody is and what they are going to be comfortable with. So you might have a patient who is really comfortable with just coming back in for routine ultrasounds, and they know that you're going to see them every 6 months, and you are going to really think about their cancer every 6 months as you're doing active surveillance. And that might be completely okay for one patient. And for another patient, the emotional stress of having to go in for that appointment every 6 months and think about, oh my goodness, is this the time when I'm going to need surgery, might be too much. So I think that really understanding where your patient is really important. In my practice, I will discuss all of the options that I think are relevant for a patient. But just because things are an option doesn't mean that it's right for that individual.
Dr. Cho, what are your thoughts about active surveillance?
I completely agree with what everyone has discussed. I think that really understanding where a patient's availability is to follow up and really commit to doing these ultrasounds. I find, especially if you're, in a catchment hospital area, which is where I also have my practice, you really want to be able to have these patients come in at a very predetermined time frame in order to really see what's going on with these nodules and really check in with the patient to make sure that they know what's going on, they know what may happen in the future, and that they still have options. And this is not something that needs to go on forever, but certainly if the practitioner is committed and the patient is committed, that it's definitely a feasible option.
Yeah, and my final comment for that discussion is we're talking about small, low-risk papillary thyroid cancers. So if you have, metastatic lymph nodes that we know about, if you have a tumor that looks, invasive on the ultrasound, you're generally not a candidate for active surveillance because we know those tumors are going to be more aggressive and have a much higher risk of spread, without treatment. So the size of the tumor, spread to the lymph nodes, the local invasion are the things we're looking for to see if you might be a candidate for active surveillance.
So Dr. Hayden, is there any particular way that you counsel your patients in terms of preparing them for surgery, whether this may be, mental or physical issues that they may encounter after surgery?
Yeah, so I generally describe the process from the moment of coming into the hospital to going home, and then the several weeks afterward. I tell them to expect usually not significant amount of pain, but I always make sure that they understand that whatever they need post-operatively, they will get from us. So if they have more pain than typical, we'll give them whatever they need to manage that. I usually will tell them, depending on what type of work they do, they could expect to take anywhere from maybe 3 days to 2 weeks off, or a little bit more in certain circumstances. And that the recovery generally is not particularly difficult or painful, but everyone's different. And so, we're always going to be there to listen to them and any sort of issues that they're having. I think we'll talk a little bit later about medication and Synthroid, but, I talked to them about that. I talked to them about the possibility of needing to be on temporary calcium supplements. And I think we'll probably get into the more detailed discussion of that coming up.
Yeah, and Dr. Ullman, there are a lot of patients that want to know if there's anything they can do to prepare themselves for surgery itself. Is there anything they can do in the weeks leading up to surgery that can improve their outcome or their recovery?
And I think that and it's not necessarily unique to thyroid surgery specifically, but increasing activity if someone is otherwise rather sedentary, getting up and moving more often, deep breathing exercises to make sure they're filling up their lungs and avoiding any potential problems with shallow breathing after surgery. But that also helps a little bit with mental health as well and lowering anxiety levels. Both in the clinic and then in pre-op as well, validating their fears or their anxieties. Nobody wants to have surgery, and we understand that. And it is very natural to have those feelings of uncertainty and fear. That is a protective defense mechanism. But understanding that there's something on the other side that we're trying to help protect you, get you better. So talking a little bit about that mental aspect, addressing some anxieties, physically, while thyroid surgery is not that demanding on the body compared to other operations that are done, it's still a good idea to make sure any comorbid conditions are as best controlled as possible, be it diabetes, hypertension. We want to make sure anybody who has underlying cardiac disease is as optimized as possible, just to make sure that the stress of the operation and being asleep in the operating room, but also to let us know how to best take care of you. So those are kind of some fine tuning in talking about what's known in the medical community as sort of a prehab or a training. You would go run a marathon cold turkey from the couch. And so while this particular operation isn't quite as physically demanding as some of the other ones that involve other parts of the body, still some basic walking and increasing the fitness will definitely help both carry them through the operation itself and then through the recovery period.
Yeah, and I have found that patients who otherwise don't really have any symptoms, once they are diagnosed with thyroid cancer, a lot of symptoms can occur kind of right after that diagnosis. And a lot of it is, the stress of a new cancer diagnosis. So I think just recognizing that we have this mind-body connection and some of the symptoms that you're experiencing, if they come immediately after knowledge of that diagnosis, may be related to the emotional response about this new diagnosis. And at least recognizing that and doing whatever you can to alleviate the stress, I think can be helpful.
Just to carry off of that too, just the physical response to the FNA, that oftentimes smaller nodules, even though you may not have felt them beforehand, the natural inflammatory response after the biopsy all of a sudden will bring it to your attention despite what the biopsy may show.
All right, so Dr. Smoot, what are your general thoughts about when a patient is appropriate to have a thyroid lobectomy, or whether you would recommend the entire thyroid to be removed?
So in terms of the extent of surgery, as an endocrinologist, I work closely with our endocrine surgeons because I think that this is a decision that is made together rather than something that we are dictating. In terms of the guidelines, nodules that are less than 4 centimeters, nodules that are not pushing up against the capsule in patients where there are no abnormal lymph nodes. Those may be patients who are candidates for lobectomy. My caveat to that is that after the surgery is done and when the pathology is being reviewed, sometimes we find that there are characteristics in that surgical pathology that mandate that we go back and do return to the operating room in order to have the remaining portion of the thyroid taken out. So from my standpoint, if I have a patient with any of those more concerning features beforehand, then that's a patient who I would not refer for lobectomy. And I also want really good surveillance of the other side of the thyroid. So if there are nodules there that meet criteria for biopsy, I would want to get that done before recommending that a patient would be okay just to have one half of the thyroid removed.
Great. So this is, again, a very, I think, important common topic. So let's get the opinions of everybody on the panel. Dr. Hayden, which of your patients do you recommend or find appropriate for thyroid lobectomy to remove half the thyroid?
So, adding on what's already been said, so there are, guidelines that we all follow, and they already were mentioned. So size less than 4 centimeters and no obvious extrathyroidal extension or lymph node involvement. But most importantly, I think that I always tell the patient, if you do fall within those criteria and you could be a candidate for lobectomy, I always tell them there is no right or wrong answer, and it really is up to the patient and not up to me, because they have to understand the pluses and minuses of both. So the major possible advantage of doing a lobectomy alone is that sometimes, but not always, patients can avoid needing to take Synthroid. Then there's also not potentially any problem with parathyroid problems or calcium problems. The downside is that there's a risk of having to go back for a second operation, which unfortunately we typically don't know until several days after surgery when we have our pathology report. So that has to be something that's acceptable to the patient, that possibility of needing 2 surgeries. The other thing I talk to them about is that surveillance following a lobectomy alone for cancer is not as good as it would be if you had had a total thyroidectomy. So we talk a little bit about tumor markers, and they also need to understand that they're going to need to have surveillance of that other lobe for, potentially permanently, but at least for a long time. And so that has to be something that they understand. So really it's ultimately always up to the patient and which of those scenarios is the most acceptable to them.
And Dr. Olin, can you talk a little bit more about that surveillance of lobectomy versus total thyroidectomy? What that looks like?
Sure. And I guess one other reason before we go off of that, I also check to see if there's any other compressive symptoms. Does the patient have Graves or other indications for thyroidectomy? There are some of our patients who can go as Hashimoto's who are already on thyroid hormone replacement, and their glands do tend to look a little bit more irregular on ultrasound. That can make distinguishing changes in nodules or changes in the remaining thyroid a little bit more challenging. And so we'll kind of talk about what would be the benefit of leaving that lobe in versus taking it out. But I also echo, it really is a team sport in this particular decision making. If the tumor is otherwise appropriate, it's just making sure the patient understands what things look like on both sides. That need for reoperation may be, a month or two later, but it also could be a few years later. If during our surveillance we see some changes, be it via ultrasound or with the tumor markers having pretty drastic changes that indicate we need to go back. And then the other question.
I think was discussing surveillance.
With discussing surveillance of the other lobe, I mean, I think the ultrasound scheduling, at least how we handle it at our hospital, at the county hospital at least, the labs and the ultrasound sequencing is the same whether you have a total or a lobe. And so they kind of all end up in the same general thyroid cancer clinic. They follow the same frequency of follow-ups, initially at 6 months and then a year, and depending on what things are looking like and the original tumor, it may get quickly spaced out to just once a year in the lobectomy group. But again, it's ensuring that the patient is committed to return, and that they understand even if they do leave, they need to continue maintaining a relationship. We'll often direct them to several of our various different professional websites to help them identify colleagues in other cities, depending on what their local resources will be.
Yeah, and so just to reiterate, our main surveillance for thyroid cancer is ultrasound. Everybody, we can do an ultrasound once a year to detect recurrence in the lymph nodes, the whole area. But if the whole thyroid has been removed, we can also check tumor markers, something called thyroglobulin. And if only half the thyroid has been removed, we can't really follow that tumor marker. So that additional piece of surveillance can be helpful for a little bit more aggressive tumors in particular. Dr. Cho, we have a comment in the chat about in the local thyroid cancer support group, 100% of the patients who had half the thyroid removed had to have a completion thyroidectomy, and the second surgery was more painful. Can you share your experience of which patients you think have needed a completion and what that recovery process is like the second time?
Sure. So a lot of the patients that that I have performed completions on may have more high risk molecular profiles, whether that's a BRAF V600E mutation, or they have more papillary thyroid cancers with such as a tall cell variant or diffuse sclerosing, which tends to be a more high-risk variant that the patient, after learning everything and counseling patients based on size criteria and everything else, that they would perhaps rather proceed to doing a completion thyroidectomy versus monitoring alone. In terms of surgery in these patients, I really like, especially when I do a lobe, part of my practice and doing my fellowship is based off the UCLA protocol, where when we do a lobe in itself, we send it for a rush interpretation in terms of pathology. And this is done, usually we get an answer back in 3 days. And so I'm able to talk to the patient, counsel them, and take them back to surgery within 2 weeks if that's the most appropriate thing for them. And I do find that whether in that approach in the short term versus long term of maybe perhaps doing a completion 3 months later after they've completely recovered and whatnot, I think that patients, again, this is all just clinical experience, do tend to do a little bit better. And I think it may just be because, again, the planes haven't had the opportunity to really heal and go through any of that scar tissue. But I don't think that, ultimately, if we were to do a randomized control trial about this, that there would be any significant changes. But certainly I do think that, those are definitely complaints that patients have and that we should discuss with them up front as well. I don't think that there's anything that, we particularly do in surgery just about doing the other lobe, because most of us do not, look at, open up that area of the contralateral lobe when we're just focusing on one side. So there's really no physiological reason why that should be happening.
And one thing though that I just want to clarify, because not every institution is going to have the pathology resources available to get that rapid a response. Even pre-pandemic, there were many of us that, our pathologists want to make sure that they can take good amount of time really being able to explore not just the small cancers, but with all of our nodules to make sure that there's nothing that's missed. But with how the pandemic has affected healthcare, we've become or at least our pathology labs become very short-staffed, and so it may take even a week or two before things are grossed, let alone when they ultimately get to the pathologist for review. And so the timing of that take back from a medical standpoint and treatment standpoint and prognosis standpoint really is immaterial. The bigger thing is, when can we safely do that operation if you need to have it? And I think, making sure that you are talking with your surgeon and going with what your surgeon's opinion about the timing of that reoperation if it becomes necessary. Not every institution has that same resources for timeline.
And in regards to this comment that, all the patients who had a lobectomy ended up having a completion thyroidectomy, I think that this has changed quite a bit over the past several years as guidelines from American Thyroid Association have been updated, that we now find it much more acceptable to do a lobectomy for different kinds of indications. Papillary thyroid cancer without any high-risk features up to 4 centimeters in size, for example, you don't need to do that completion thyroidectomy. I think this is important to understand with your treatment team, in which case would they think the entire thyroid needs to be removed, and how much of that can be figured out ahead of time. Some patients, there's a nodule that has an uncertain biopsy result, not sure if it's cancerous or not, and then you have the lobectomy, you find out that it's cancer, and then maybe the treatment team will recommend that the other half of the thyroid needs to be removed. But there are, I think, a lot of surgeons who would say, even if we know that it's cancer ahead of time, because it's small, completely contained within the thyroid, we don't see any spread to lymph nodes, we're going to be comfortable with just doing the lobectomy, even if it ends up that it's going to be cancer. So I think it's helpful to try to get an understanding from your treatment team, what are the possible outcomes of the surgery, in which case would the other half need to be removed at a subsequent time? How likely is that to happen? Because we all would like to avoid that second surgery for you, if at all possible.
And I think too, if I might add, your point earlier about sometimes patients feel regret about making a decision. Well, certainly we wouldn't want to commit someone to have a total thyroidectomy if we can save them from having to be on lifelong thyroid hormone supplementation, if in fact it does have final benign pathology or very, very low risk pathology.
Which leads us actually to the next comment in the chat. This will be for Dr. Smook. Some people, this is from the chat, think that if they only have half the thyroid removed, they will not have to take thyroid replacement hormone. But in most cases, they still need thyroid hormone replacement, even if they've just had a lobectomy. Is that correct? What is your experience, Dr. Smook?
That is correct. It's, well, we would love to be able to predict prior to lobectomy exactly who is going to need thyroid hormone supplementation and who is going to be okay without it. We can't always do it. There have been studies that have shown that if your TSH is less than 3 prior to surgery, then it's likely that you won't need thyroid hormone supplementation afterwards, but it hasn't borne out in all of the repeat evaluations of that data. So the way that I counsel my patients about it is that if we are doing a lobectomy in the hope that you won't need any thyroid hormone replacement, we can closely monitor, we'll evaluate thyroid function a couple of weeks to a month after surgery and see where things are. The place where it becomes a little bit more tricky is if you did end up having a lobectomy for thyroid cancer, we still don't want to let the TSH drift up too high. So if you had a lobectomy and the pathology was benign, having a TSH of 4 would be perfectly okay. But if it's been for a thyroid cancer, we would like that TSH to stay less than 2. And it's hard sometimes to predict when we're going to be able to do that without any medication at all.
Yeah, that's an important point. There are studies that say that the other half can start to compensate, but it can take many months, even up to a year, which we can do with benign disease. But for some, for thyroid cancer, we may not want to let that happen because there could be an increased risk of recurrence if you're hypothyroid for that length of time. So next, I'd like to go to one of our participants, Ms. Jenna Hefner. If you could just, you're welcome to unmute yourself and just share the experiences that you've had. We would love that.
Good morning. Well, for me, it's morning. I'm in Southern California, Thank you all for putting this together. I think it's really important.
I'm sorry, Ms. Hefner, can you just speak up a little bit more?
Oh, sure. Is that
Thank you.
better?
That's great. Much better.
Okay. So I'm 30 years old. I had a diagnosis of papillary thyroid cancer with a follicular variant in February of 2018. And my symptoms started maybe the previous October around that time, and I had symptoms of a really extreme fatigue. That was the most pronounced. I didn't have any pain, and then I had a routine physical, and the physician noticed a lump in my neck and referred me for an ultrasound, which led to a biopsy. The biopsy came back as indeterminate, so my medical team let me know that their recommendation was that I have that half of my thyroid removed, but that it was up to me ultimately. And so I decided to go ahead with it. And then after, when I went to have my stitches removed, they confirmed that it did test positive for papillary carcinoma with the follicular variant. And the surgeon had said that due to that he wanted to go back in and remove the other half. And I think at the time I wasn't really aware of my option to just kind of watch and wait. There weren't any nodules on the other side of my thyroid, and so sometimes I do wish that had been part of the conversation. But at the same time, just as everyone has been talking about, it's a tricky thing to leave half in the hopes that maybe everything will be fine. So that's what happened for me. And then I had a recurrence last summer. And that was reflective in my a little bit of an increase in thyroglobulin and some nodes on the ultrasound that looked a little bit suspicious. I didn't have any biopsies. They just had me take around 55 millicuries of a radioactive iodine. And so now things look okay. And I think what I deal with the most is still feeling some level of fatigue and the frustration around feeling like I'm always needing to have my medication dosage changed. It feels a little bit like a roller coaster. But, all in all, I'm obviously thankful for the fact that I had a great medical team, and I continue to receive really, really great care at City of Hope in Southern California. So that's my experience.
Thank you so much, Ms. Hefner, for sharing that. I know that there are many other people on this call and who may listen to this later on that can have the same exact experiences as you. So thank you for being able to share that with us. In kind of in line with some of the symptoms that she described, Dr. Smook, do you feel that fatigue is a complication or a symptom that patients feel after thyroid cancer surgery?
I think that fatigue is something that we hear about a lot from our patients, not only those who have undergone surgery for thyroid cancer, but in our endocrine patients more broadly. I think it's a really difficult symptom to get to the bottom of. And when we're looking at thyroid levels, the way that I'll often counsel my patients about it is if the thyroid level aligns with the symptoms that you're having, then we can blame the thyroid, and most likely we can fix it with titration of thyroid medication. If the symptoms don't align with what we're seeing on the blood tests, then we've really got to take a look at what else is going on in someone's life, what other medical issues might need to be investigated a little bit further. And then, as you guys brought up before, we can't underestimate the emotional burden of a cancer diagnosis. It's very real. And one of the things that I talk about with my patients all the time is that most often, when it comes to thyroid cancer, it's not that you've gone to the doctor with a bunch of symptoms that you're trying to figure out and work through. People are usually asymptomatic, other than, maybe some swallowing difficulty or compressive symptoms if the cancer or nodule is big at the time of presentation. But then, as the woman who just spoke, it talks about, then all of a sudden we've noticed something on physical examination. We're sending you for ultrasound. We're sending you for biopsy. You're meeting with a surgeon. You're being given a diagnosis of cancer. And while most of the time we can tell you that that cancer is going to be really manageable, the emotional stress of all of this is really, really real. And while hopefully, within a year, we've got your thyroid medication leveled out and those issues are okay, it doesn't mean that we've gotten to the bottom of all of the emotional stressors that are related to it. So one of the things that I use really often in my patients is a resource we have at UCLA that provides really comprehensive care for cancer patients who've been given any cancer diagnosis, and really help to work through the emotional side of this while we can work on the physical side of it and the biochemical side of it. So I think that somebody referred to us earlier as a team sport, that people who are able to help us talk through some of those issues are a really integral part of our team.
Thank you for that, Dr. Smook. And just to plug in our partners here today with ThyCa, they've developed a really large thyroid cancer network where people can come together and really support each other. And I think going along with what Dr. Smook said, it's really important. And just as you are all coming here today so we can talk.
Yeah, and I'd like to read a comment that was made on the chat. As a support group moderator, facilitator, we hear all of the problems. There seems to often be a lack of continuity of care, community-based endocrinologists with little education or expertise in thyroid cancer care, not enough cancer concern about quality of life. Other cancers and diabetes patients receive a lot of education and nurse support, which seems to be lacking in thyroid cancer care. So yeah, this is kind of the whole purpose of the session that we're having, the work that we're trying to do through the American Association of Endocrine Surgeons in partnership with our patient advocacy groups like ThyCa, to provide resources for people that maybe don't live right next to Cleveland Clinic, where they can get the expertise care here. And we do see that, yes, a lot of attention often is paid to diabetes, for example, that can really be predominant in a community. So we recognize that, and we're trying to partner with all of you to improve the resources that you have. So let's switch gears a little bit and talk about some specific details of thyroid surgery and some potential complications. So we'll go back to Dr. Hayden. Can you talk about the complication of hoarseness after thyroid surgery? How often does this happen? Is there anything that we or the patient can do to try to minimize that?
So there's several different types of hoarseness that can occur after thyroid surgery. So much more commonly is a temporary hoarseness or temporary weakness of the voice. That probably happens. It's difficult to say for sure the risk of any of these things, but we think that happens maybe 5 to 7% or something of the time. That's something that we think is probably from intraoperative irritation to a voice nerve and or swelling and irritation from the breathing tube and the surgery itself. Those types of that type of hoarseness will get better and essentially go back to normal with time. A very different scenario is if one of the voice nerves is transected during surgery. Usually that is something that's recognized during the operation by your surgeon. That causes hoarseness that generally does not recover on its own completely back to normal. That sometimes requires an intervention, oftentimes by our ENT colleagues. And sometimes when there's initial hoarseness after surgery, if a patient has any kind of voice changes, I say, as long as they're able to manage it in the interim, I say, well, wait several weeks to months, and then if it's not improved, we'll do a formal evaluation, which is looking at the vocal cords. That would be in the scenario where there was not any recognized injury to the nerve. Now, another scenario would be if you have invasive cancer that is either invading the nerve or very closely adherent to the nerve. A lot of times, but not always, those patients will have hoarseness prior to the surgery. So you may recognize that. That would be one of those rare symptoms of thyroid cancer. In those scenarios, we will usually look at the vocal cords prior to surgery so that we can understand the status of both nerves, and that will also oftentimes influence the surgery that we offer. When that's not recognized preoperatively, but it's something that's found intraoperatively, there's several different, sometimes we always try to save the nerve. And in those cases where the nerve is spared, we would anticipate, again, recovery of the voice with time. If you cannot spare the nerve, and in order to resect the tumor completely, you have to, take part of the nerve, then that would be something that would then not be expected to recover and would probably be someone that we would refer to ENT for, management of that. So those are some of the different scenarios, but, the overall risk of having a nerve injury is probably around 1.5%.
Thank you, Dr. Elbin. Will you tell us a little bit about the complication of low calcium?
Sure. So with surgery, there are the parathyroids that are 4 little glands that live in close proximity to the thyroid. The parathyroids really help manage the calcium levels in our body. And during surgery, we try to very carefully push them down off of the thyroid to keep them safe. But the blood supply, or sort of the power lines to and from the parathyroids, are very closely tied to those of the thyroid. And so sometimes during surgery, either they can come out attached to the thyroid, being stuck to them, or in the process of taking the thyroid out, the blood vessels to those very tiny little glands could be damaged. If that's something that we see during the operation, we can actually separate the parathyroid off of the thyroid and chop it up in really fine bits and put it back in the muscle in your neck for it to try to regenerate. But in cases where we have a big bulky tumor, a lot of bulky lymph nodes right around the thyroid, we may not be able to really separate one or more of the glands from what needs to come out, or to feel confident in the ability to separate and know that what we would be putting back in is actually parathyroid tissue and not either a cancerous thyroid nodule or cancerous lymph node. In cases where even if the parathyroids look fine, we still would rather have a good proof that they're working properly, and that the hormone that they make is one that the body burns through from a minute-to-minute basis. So we can check your blood work in the recovery room to have a good idea of whether or not you're at risk for having issues with low calcium, to be able to start you on calcium supplementation and potentially even a form of vitamin D to help your body absorb calcium a little bit better. There are other thyroid problems that may cause you to have a higher degree of calcium need, or previous surgeries like gastric bypass that would also make you more prone for this particular complication. And so it is very important that you disclose all of your surgical history with your surgeon. And then conversely, if you are a thyroid cancer patient and you have had thyroidectomy, and you need calcium supplementation, if you then are going to consider bariatric surgery, you really want to make sure you talk to your bariatric surgeon about that as well, because what surgery they should offer and do is very different if you already have this pre-underlying issue with low calcium. Supplementation for a few weeks is, for the vast majority of people, all that is necessary. I usually will tell my patients about 15% of people will need to be on some short-term calcium for the first few weeks. usually less than 1%. Would that be permanent? And I think the patients that end up having either larger tumors or central neck dissections because of the extra tissue we need to take out in the space of the parathyroid lip are the ones who are at the highest risk.
Thank you, Dr. Ullman.
And there's a question in the chat about baseline vocal cord assessment. Is it routine to perform evaluation of the vocal cords before any thyroid surgery? Which I'll just answer. It's really dependent on who your doctors and who your surgeon is. There are some surgeons that just routinely like to assess the vocal cords before any thyroid surgery. I think probably most of us in this community will do it more selectively. If the patient has, normal voice, no voice change, and a tumor that does not look very invasive on the ultrasound, it's not really in the vicinity of the vocal cord nerve, that we don't have any reason to suspect the nerve could be affected by the tumor. A lot of us will not do that baseline vocal cord assessment, but it really just depends on the preference and practice of the surgeons who do their surgery. I'm going to direct this to Dr. Choa. Can you talk about pain control after thyroid surgery? What is a strategy to manage pain? How often are narcotics needed? Is it different if you just have your thyroid removed versus a more extensive lymph node dissection?
So I think in general, pain after surgery in the neck is very well tolerated, but I'm very upfront with all my patients preoperatively when I'm evaluating them for surgery about pain to let them know what my general strategy is. I typically always use Tylenol and ibuprofen and always say if pain is uncontrolled in the immediate postoperative period in the PACU and they feel like they need to go home with something stronger, I'm more than happy to give any opioids or narcotics if needed. But I do feel like the pain in the neck is very well tolerated for these patients. And I also perform cervical plexus blocks as well during surgery, which I think really helps. So I think knowing the patient's expectations up front and them understanding expectations after surgery, I think having that conversation before surgery is really important. Doing other things such as, icing the neck, especially for the first 3 days after surgery, I think is really helpful as well. Dr. Smook, is there anything that you particularly talk to patients about life after thyroid surgery and how this may be different than your life prior to surgery?
So one of the things that I like to talk to my patients about, if I have the benefit of seeing them before they've had their thyroid surgery, is any symptoms that they're having prior to surgery. So if we have someone who has been a little bit cold and a little bit constipated their entire life, then what I tell them is that after surgery and after I put them on thyroid medication, I expect that they are still going to be a little bit cold and a little bit constipated. Because if I'm giving them so much thyroid medication that I get rid of those symptoms, then we are probably over treating them. So in a nutshell, it's basically a discussion of the fact that you are going to be the same person following surgery that you were before surgery, and we don't expect the thyroid medication to change that in a significant way. We talk about symptoms that we can have from either too much thyroid medication, like feeling more anxious and jittery and maybe having your heart race and your hand shake and feeling a little too warm. Bowels might be a little bit loose, and feelings of too little thyroid medication might be feeling more cold, constipated, more tired than usual. And some of those symptoms could be somebody's baseline. So again, we're not going to change them. In terms of how we estimate how much thyroid medication someone is going to need, we use a formula. It's 1.6 to 1.8 micrograms per kilogram of ideal body weight. And then we know that some people are going to need a little bit more, some people are going to need a little bit less. And the way that we figure that out is by having a discussion about it and by getting blood work done to assess where the TSH is. In terms of how patients can best optimize their chances of doing well with thyroid medication, I always explain to people how to take their medication properly. So thyroid medication is a little bit finicky and sensitive, so it should be taken on an empty stomach. And that can either be first thing in the morning, or it can be at night before you go to bed, as long as you haven't eaten for about 3 hours. There's no need, from my standpoint, for somebody to wake up in the middle of the night to take their thyroid medication. The thyroid medication itself should not be life disruptive. The other things that people can do to optimize their absorption, other than taking it on an empty stomach, you want to wait at least 30 minutes before eating or drinking coffee. And you want to take your medication at least 4 hours away from supplements that contain calcium, fiber, iron, and soy. And that includes multivitamins and prenatal vitamins. And I often find that if people are being careful about the way that they're ingesting their thyroid medication, we can get their levels to be pretty consistent. There are other factors. We mentioned gastric bypass. If patients have celiac disease, the absorption might be a little bit less consistent. And those are things that we work out with individual patients.
Thank you so much. I think what I heard from Dr. Smook is that the being on thyroid hormone should not really change your personality or your quality of life, as long as we are adjusting the dose appropriately. I think this is one of the most common concerns, that people have, is how will I feel different when I'm on thyroid medication? Will it really change my quality of life? But I think what I heard from Dr. Smook is that it really shouldn't. The same person that you were before the surgery is the same person that you would be afterwards, with the caveat that we have to really just make sure that we have you on the correct dose of medication. Okay, so switching gears a little bit more, and we had some question in the chat before this as well. Let's talk about radioactive iodine ablation. So Dr. Hayden, what do you feel are the indications for radioactive iodine ablation for thyroid cancer?
So the indications for iodine are similar to the indications now we use when we're thinking about doing a lobectomy or total thyroidectomy. So in general, tumors, larger tumors that have extrathyroidal extension, tumors that have lymphovascular invasion, or more aggressive appearance under the microscope are generally referred for radioactive iodine. One thing to keep in mind is that radioactive iodine cannot be given to someone who has only had a lobectomy. So that's really, in large part, the underlying reason that a lot of times we'll do a completion thyroidectomy on someone, because in order to be able to give radioactive iodine. So if we determine based on their pathology and clinical pathologic features that they need iodine, then they would need to have a completion first if they had, upfront had a lobectomy. Ultimately, often at the Cleveland Clinic, we will have, we have a thyroid cancer tumor board. A lot of other institutions also do. And so oftentimes we will discuss individual cases with the question, the main question being, should this patient receive iodine or not? So it is an individual decision. Another factor that comes into it is I will, if someone's sort of in a gray zone and there's not an absolute indication for it, I'll have a talk with a patient and ask them how they feel about it, because some people have a fear of radioactive iodine and other people would much rather be more aggressive with their treatment. So it's also, in some cases, there's, a lot of room for patient input and patient preference for that.
Great, thank you. Dr. Ullman, anything to add about which patients you think need to have radioactive iodine ablation?
Sure, but I do want to revisit a topic though real quick, just so advocating for the patients, and from what I personally experienced when I had to have my thyroid taken out. I'm just going back to talk a little bit about post-op pain expectations, because I think most people, when they have a surgery, they assume that the incision itself is what's going to be hurting them. And with thyroid surgery, usually the incision pain is one piece of it, but the sore throat is actually, and the best thing I can describe it as is like swallowing razor blades, or when you were a kid and you had strep throat. And unfortunately, prescription pain medicines don't really target that at all. Ibuprofen can help. Throat lozenges designed to help people when you have sore throat, whether it be for strep or for other reasons, can help. And modifying your diet to eat softer foods, trying to modify the temperature slightly as well to provide some relief. I think talking about that in advance and setting those expectations really can help because it is frustrating because you want to clear your throat. You've got a lot of secretions in the back of your throat from the endotracheal tube when you wake up. You try to cough to get that out, and it really does feel like there's razor blades in there. So I think talking about the expectations, making the comparison to other times that you've experienced that same sensation in your life, and knowing what is it that's going to help. So in the chat, Dr. Boone is mentioning there are some cough drops that you can get that actually have a numbing agent to help your throat, or there are a few different sprays as well. The other part that I found that was actually what lasted the longest was musculoskeletal pain on the back of the neck. And the duration of the operation is a big impact on that. Many patients experience this to a much milder degree when they have their biopsy because of the position that they're in during the biopsy. We set the expectation you're in that same position during the surgery for the whole time. And muscle relaxers, in addition to ibuprofen, Tylenol, a mild narcotic, can help with that. That may also help address any headaches that you have after surgery because of tension headache on the back of your head. And then if you are sensitive to migraines, that can become a trigger for you. And so talking through all of these and realizing there's lots of ways that we can target your discomfort after surgery, but also being able to match what treatment is going to help your pain. And I think oftentimes in healthcare, we don't do a good job just asking, well, tell me about your pain. Where is it? How does it feel? What part of the body? And that we need to really customize which treatment's going to help what's causing you the most discomfort after you have your surgery. Sorry. Back to radioactive iodine, the side effects, and with side effects of REI usually are pretty minimal. I'll usually counsel my patients who can have a headache or some nausea and vomiting in the first couple of hours of the treatment being given. That usually goes away. The more common thing, and it's still not that common, but people will talk about some discomfort in their salivary glands. That may just be simply discomfort or pain. That may also trigger some dryness of mouth. That duration can be variable as to how long it may last. And if someone does have some issues with permanent dry mouth, it can have also some impact on your teeth, and just understanding that you need to seek out a special dentist who has some familiarity with the lack of saliva that's being produced, and they may recommend a special mouthwash for you and a special type of toothpaste to really help protect your teeth. Thank you. And Dr. Smook, maybe you can be our nuclear medicine doctor for today. Can you talk a little bit about thyrogen versus withdrawal for radioactive iodine ablation? What are the differences? And a lot of I think patients that live in more community-based settings, they don't really have access to thyrogen. It's not given as an option. So can you talk about the experience of withdrawal, and when do you think one would be better than another?
Sure. So thyrogen is a medication that helps to stimulate the TSH to make your body more avid for the radioactive iodine. And when we can use it, I think in terms of quality of life, it's a lot easier for our patients to be pre-treated for radioactive iodine with thyrogen versus withdrawal. We don't currently use much thyrogen when it comes to radioactive iodine being used for treatment of metastatic disease, because that's a place where we still think that the withdrawal is superior to thyrogen in terms of making sure that your body is seeing enough radioactive iodine for an adequate period of time to help optimize treatment. In terms of preparation for radioactive iodine, I often think that the preparation for it is actually harder than the treatment. We are subjecting you again to more medical appointments. You're now meeting with a nuclear medicine physician. You have to go on a low iodine diet. If you are getting thyrogen, you're coming in for thyrogen injections on the 2 days prior to your treatment with radioactive iodine. If you're not able to have thyrogen, then we're subjecting you to withdrawal from your thyroid medication. And most of the time, what we'll do is stop your levothyroxine or Synthroid 4 weeks prior in order to give time for that medication to completely wash out of your system. But we can bridge you with the short-acting thyroid medication, which is liothyronine or Cytomel, which is T3. And you can take that for the couple of weeks prior. We usually stop that medication about 1 week before your radioactive iodine, again, to allow your TSH to drift up and make your body more avid for the treatment. And during that period of time, patients feel really hypothyroid. So you are going to have all of those symptoms of feeling tired and cold and constipated. Your mood might be a little bit low. And I think that's a great time to remind the people you are working for and your family that you need to be cut a little bit of extra slack during that period of time, because you are just not going to feel like yourself. You know, if the radioactive iodine is necessary and that's the way that, you know, your medical team feels that you need to proceed, and withdrawal of medication is the only way to do it, then you will make it through that period of time, but it can be challenging.
Thank you, Dr. Smith. I think we talked about surveillance, ultrasound, tumor markers. So this question will be for Dr. Ochoa, because this is another common scenario that our patients find ourselves in. What does it mean if the thyroglobulin is a little bit elevated, but we can't find any tumor recurrence? So you have thyroid cancer, the whole thyroid had been removed. Now your tumor marker is a little elevated, maybe even rising a little bit, but we can't find anything on the imaging.
So sometimes this can occur, especially, you know, if there might be some micrometastasis or perhaps just some cells of thyroid cells that have been left behind, but they're certainly not big enough for us to identify in the ultrasound. The ultrasound is a really, really great tool when we're looking at the thyroid and when we're evaluating anybody for thyroid cancer and lymph nodes, as we've previously discussed. But there's also a margin of error in terms of how sensitive these can be. You know, if there is something that's, you know, very small, 1 to 2 millimeters, those are things that we're not going to be able to pick up on the ultrasound, but it's still completely appropriate just to follow these thyroglobulin levels, perhaps in a shorter term than just, you know, the 1-year surveillance ultrasound that we had previously discussed. Sometimes this can be done in 3 every 6 months, just depending on the patient's particular situation and the degree of elevation in the thyroglobulin. Again, just like everything we've kind of discussed here, this is really personalized for the patient. So depending on what our you know, degree of suspicion is, and will determine kind of how we continue to follow this up.
Dr. Hayden, how do you manage these patients in your practice that have this little rise in thyroglobulin, but you can't find any disease recurrence?
So I agree with the same way. So it's either indicating that you have some microscopic residual disease, and that could be in your neck, or that could be in your lungs, that could be, you know, anywhere, but too small to show up on any sort of imaging. So one, you know, we would likely start with a neck ultrasound. If there's nothing on the neck ultrasound, then the next step would be other imaging, and there's different modalities and different ways of doing that. You can get CAT scans of the lungs, would probably be, you know, one of the first ones. Another thing that can be considered, and again, this is very individualized, is that you could do another iodine uptake, like a diagnostic uptake scan, etc. And if nothing is found, then the options would be close observation. So you follow, you know, at least every 6 months. And if things start to continue to go up, then you know, continue your investigation to try to figure out where it's coming from. Another option, again, depending on many factors, would be an additional dose of radioactive iodine. And that would be something that you would discuss with your endocrinologist and your whole team to see if that would be appropriate. And again, it's going to depend on many, many different factors. But what you would not do would be some sort of surgery to, you know, look for something. You wouldn't do any kind of operation without a target.
Yeah, and I'd just like to add, I think this decision about whether any additional treatment is needed, like radioactive iodine ablation in this scenario, it's a really important decision to discuss with your treatment team. You know, the thyroglobulin is a number. Yes, it represents that there's, you know, probably some little bit of disease somewhere, but a number itself is really not going to hurt you. We have so many patients whose, you know, thyroglobulin maybe is not perfect after thyroid cancer, but they're going to live a long, healthy life, and, you know, really without bad effects from their thyroid cancer. So I think to probably not overreact to a number on its own, just make sure that you're really comfortable with your treatment team, that they're experienced with thyroid cancer, get the imaging that you need, but not to overreact maybe too much to the number itself.
Well, and I think it's also important for our patients, since all of them are going to be coming through a different journey. The thyroglobulin also has to be taken into context, whether or not you received radioactive iodine. Normal thyroid cells also make thyroglobulin. And so if there's a little bit of normal thyroid left in an ectopic location, that also could be potentially causing this production. Usually if you've had radioactive iodine, that radioactive iodine should knock out that normal thyroid tissue first. And then during this period, has your TSH been appropriately suppressed? So has your thyroid medicine been at the right dose for what we need it to be doing? And if there's been big fluctuations in how well your thyroid medication has been working for you, that can also cause big fluctuations in what we see in the thyroglobulin. So there is quite a bit that we need to be looking at when we see changes. And so your doctors may talk about a stimulated thyroglobulin level versus a suppressed thyroglobulin level. And that really has to do with how your thyroid medication has been keeping things sort of quiet or asleep, so to speak.
Yeah, and I'd love to hear Dr. Spook's opinion or perspective, because I know she has a lot of patients in her endocrinology clinic who are probably in this scenario. And then Dr. Spook, you could also address this excellent comment in the chat about what about if there are thyroglobulin antibodies, and what about biotin interference?
They're great questions. I couldn't agree with Dr. Livitz more that sometimes a number is just a number. And as long as we aren't seeing anything anatomic or we're not seeing that number changing quickly, we will often just monitor and watch. And sometimes we also monitor and watch small lymph nodes or small nodules that might appear a little bit abnormal, because we need to make sure before we send somebody back for more treatment, whether it's surgery or anything else, that they really need it and that their disease merits that kind of treatment. I often use the adage, we have to make sure that the punishment fits the crime. So there's really no crime most of the time in having a little bit of thyroglobulin elevation or a really small little lymph node that we are keeping an eye on. In terms of antibodies, when we are surveilling for thyroid cells, we are looking at two numbers. We're looking at the thyroglobulin and thyroglobulin antibody level. And about 25% of our thyroid cancer patients have a positive thyroglobulin antibody. And what that really means in terms of your management is that it's very hard to actually calculate how much thyroglobulin is there in the presence of a thyroglobulin antibody. And so sometimes we need to send off tests to a specialized lab so that we can get a little bit more information. There are some assays that are able to kind of remove that thyroglobulin antibody effect so that we can look at the thyroglobulin. And there are also some labs where we can use the thyroglobulin antibody as a surrogate. So if that thyroglobulin antibody is going up, we can say there's more likely to be disease there. If it's staying stable, we can say that it's more likely not to be a problem. And in terms of where those levels are sent will really depend on what's available in your community where you're being treated. The other question that came up about biotin, this has become a big a big topic of conversation as people are taking biotin for a multitude of different reasons, be it for hair loss, for skin, for other things. And we do know that doses of biotin, usually in excess of about 5,000 micrograms, can disrupt our assays. So it's not that it's causing thyroid cancer recurrence. It's not that it's causing your thyroid medication to not work. But a lot of hormone assays are run on what we call a biotin streptavidin platform. And so if you were taking biotin, it can disrupt the way that that assay functions. The good thing about biotin is it's water soluble. You pee it out for the most part. And so you can stop taking your biotin for about 3 days before you have blood work done. And that should wash out of your system and then not disrupt your blood work.
Very helpful. Thank you.
Dr. Altman, what are the treatment options for recurrent papillary thyroid cancer?
So some of it depends on where we see the recurrence. So in general, if the recurrence is in the neck, one will want to make sure it gets to, and I think every surgeon might have a slightly different size cutoff, but we want it to make sure that it's a size at which we can reliably find it. If it's an area that we've operated on before, finding something very, very small under a centimeter in a lot of scar can be challenging, especially if there are other things like your nerves that we want to be able to protect. And so if it's an area that has not had surgery before and we see that it's amenable to surgical excision, then usually that would involve a neck dissection. Most commonly, this would be a lateral neck dissection, although sometimes if your central neck was not fully explored during your thyroidectomy, it may be your central neck compartment as well. If you have had multiple recurrences and your neck is deemed to be hostile, meaning there's lots of scar tissue there, either from previous surgeries or if you had a much more aggressive tumor and underwent something like external beam radiation, which is exceedingly rare, we may not choose to offer surgery for fear of causing more damage than would help. And in that case, there are some options for ethanol ablation, especially if it's just one small site that they can ablate. And I believe that people are also starting to use RFA as well as an option, but that RFA is not as widely available.
Thank you. And Dr. Smook, what are the treatment options for metastatic papillary thyroid cancer outside of the neck?
So disease outside of the neck, we do have more treatment options than we did in the past. And decision about when to go to systemic therapy should be done, again, with your whole treatment team, often including an oncologist. And we tend to reserve these treatments for disease that is either iodine refractory, meaning that giving more radioactive iodine is not going to be of benefit anymore, or if disease is growing a little bit more quickly and patients are starting to have symptoms from the disease. So those treatments include tyrosine kinase inhibitors, which are oral medications that can be taken to help slow the growth of thyroid cancer. And there are also other more targeted treatments being studied that would be given based on what the molecular diagnostics are on your specific thyroid cancer pathology.
Okay, perfect. You're leading us right to the next topic. Just one last quick question for you, Dr. Smook. There's a question in the chat about, does it matter how you are prepared for withdrawal when you're getting radioactive iodine? So specifically, if the doctor is recommending 2 weeks of withdrawal versus 4 weeks, is that adequate? If the TSH is 20 before radioactive iodine, is that adequate?
So different centers, I think, are going to have slightly different protocols. The half-life of levothyroxine is about 7 days. And depending on your renal function and on other factors, it could take a little bit more or less time for that levothyroxine to wash out. And yes, I would agree that we need a TSH level of at least 20 before we treat with radioactive iodine. In terms of the specifics of the timing, I would take a look at what the protocols are at your institution. At ours, it's 4 weeks off of levothyroxine using T3 in order to bridge so that patients are having less symptoms.
Great. Thank you so much, Dr. Smook. And Dr. Smook needs to leave a few minutes early, but we really want to thank her so much for participating and sharing the endocrinology perspective with us. Thank you.
Absolutely. Thank you for including me today.
Okay, so the next question is for Dr. Hayden. Can you talk specifically about papillary thyroid cancer with a BRAF V600E mutation? How does that change the prognosis and treatment?
So very, very good question. And there's a lot of information that we know and a lot that we're continuing to learn. We know that generally speaking, those tumors have a more aggressive biologic behavior. We know that they are more likely to have, lymph node involvement, and most likely, again, there's so much data there, but a higher chance of recurrence. In spite of that knowledge, most institutions and individuals don't, and our guidelines don't specifically use that information, the presence or absence of a BRAF mutation, to guide therapy. That I think will probably change in the near future as we have learned more and more about the different biologic behavior of BRAF mutation versus, BRAF wild type. So it's a very much an evolving area that we're learning about, rapidly.
Great.
And Dr. Altman, what about the prognosis and treatment of Proto-Cell carcinoma?
Normally this is when I would turn to one of my endocrinology colleagues, Dr. David McFadden, to take this one as far as our patients locally. But with Hurthle cell carcinoma, usually the key is ensuring that you get a good, adequate surgical excision, ensuring that there's no violation, because these can have a tendency to recur locally and need further surgery. However, if it's removed surgically intact, usually that should not be as much of an issue. One thing with Hurthle cell that tends to set it apart from a lot of the other differentiated thyroid cancers is it's a little bit less responsive to radioactive iodine. It just doesn't tend to pick it up quite as much. But in general, the patients with Hurthle cell carcinoma, as long as it's a smaller one, still tend to do fairly well. It's more so if it's a very, very large tumor, multiple centimeters in size, that it can become a little bit trickier dealing with recurrences in the neck.
Great, thank you so much. We had so much great discussion. We didn't get through all the slides, which is totally fine. So just as a quick summary, I think this is, some of the messages that we want patients to know is that most patients do not die from thyroid cancer. Of course, thyroid cancer does have the potential to spread, to impact your life, usually requires treatment like surgery, maybe radioactive iodine ablation, but generally, thankfully, has an excellent long-term survival rate. You're talking about for your entire life. However, recurrence can definitely occur, and I think that's something important for patients to be aware of, and to know, if there's anything they can do on their part to try to limit that. And I think the most important part of that is just make sure you're really comfortable with your treatment team. Because the reasons that patients recur are, one, the biology of the tumor. The tumor just is what it is. It has certain mutations that drive it. Some tumors will be more aggressive, may present with lymph node disease. Others are really small, contained within the thyroid, will have an excellent prognosis regardless of what we do. So there's the part about tumor biology that we really can't impact. This is how you present with the tumor. But then the part we can impact is the adequacy of the initial surgery. Really making sure we completely remove the tumor. We look very closely to make sure there are no lymph nodes involved that we have to remove. Do we need to do a total thyroidectomy? Is a lobectomy okay? So that's the part that we as the treatment team can do to try to minimize that risk of recurrence. And so I think from the patient's perspective, just making sure that you're comfortable with your treatment team, that whoever it is that they might be in your community, that they take care of a lot of thyroid cancer patients. And that finally, there's a lot of individualized management that's now available for thyroid, we're talking about for mostly papillary thyroid cancer. It's not a one size fits all anymore. There's a lot of nuance on extent of surgery, whether you need radioactive iodine ablation. And these are a lot of things that you can really discuss with your doctor to make the best decision for yourself, because a lot of that depends also on the patient values. So there's some cases that are black and white, and this is, for sure, this is what a patient needs. But I think a lot of cases are more nuanced. And so for us to have a really, really clear understanding of what your priorities and values are, we can help, together make the best decision. Anything that you want to add, Dr. Cho?
Again, I just can't emphasize enough how individualized this treatment is. And even all of you on the call, all of the you as patients who've been asking questions, it's really important for us as physicians as well to continue to treat you, because for every one of you who asked that question or was able to speak up on this call, there are thousands more who are experiencing the same thing. And or have the same questions that may not necessarily have the confidence to ask them. So it helps us, again, help develop a treatment plan that's important, that both the patient and the physician can come to together with their team.
Yeah, and ThyCa has an upcoming conference that will be September 16th through the 18th. It is a free conference. There'll be much more information specifically geared towards patients. The information is on thyca.org. So that's www.thyca.org. And I'd really like to just thank our panel one more time, Dr. Katie Hayden from Cleveland Clinic, Dr. Sarah Altman from UT Southwestern, Dr. Stephanie Smook, who works with me at UCLA, and Dr. Joanna Ochoa, who is at University of Florida, Jacksonville. Thank you all so much for participating.